Hello, I'm Dr Louise Newson and welcome to my podcast. I'm a GP and menopause specialist and I run the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the Menopause Charity and the menopause support app called Balance. On the podcast, I will be joined each week by an exciting guest to help provide evidence-based information and advice about both the perimenopause and the menopause. So today on the podcast, I've got someone called Faiza Kennedy, who is one of the few people that I do on my podcast I actually know and I've seen in real life, which is wonderful because so many of my guests are not people that I've ever met in real life. But Faiza works very closely. She's one of our most senior pharmacists and I'm very grateful for all her work. So I thought today I would quiz her a bit about what's it like being a pharmacist in the menopause world, and also to talk about some of the HRT shortages, which, as many of you know, are ongoing and incredibly frustrating. So welcome, Faiza. Thanks for coming today.
Thank you for having me.
So when we first met, I think you'd emailed me and we were sort of pen pals for a while, weren't we? And then you came and sat in the clinic.
Yes, so actually I heard you being interviewed on the Oral Apothecary podcast, which is one of my favorite podcasts, and actually hosted by three of my really good friends, Jamie, Paul and Steve. And I heard you on this podcast and I thought, my goodness, I have to meet this woman. And forced Jamie to introduce us, and then stalked you by email, and you invited me up to the clinic, which was lovely. And then yes, a year on, I'm still here, and I love it.
Which is great. So
yes.
But you haven't always done menopause work, have you, as a pharmacist?
No, I've had quite a varied career, but I suppose my last role was in general practice, which I loved. But if I'm honest, I've always liked the kind of the prevention, and then of course, once you see it, you can't unsee it, can you? So it's that joy, you know, when you see the difference. My favorite is seeing the follow-up patients, because you just see that it's almost like the women become into focus, and they, you know, the ripple effect on their families, on their work life, on everything. It's just joyful. So yes.
It's very transformational. I was talking to someone this afternoon actually, and saying whenever I get stressed or I get overtired or just everything's a bit overwhelming, I just sit in my clinic and see patients, and it's very powerful. I've always been jealous of my husband, who's a surgeon, because he can really transform people's life when they're having an operation, of course. But in general practice, I always felt that I wasn't quite doing enough, and I always felt that I couldn't really make a huge difference. I could make some difference, of course, but doing menopause care really is transformational, isn't it? There's very few things in medicine that I see people and say, I don't know how much I'll make you better, but I know this is probably the worst you're ever going to feel. And like you say, the first review, you start to see a difference, and then by the second or third of my annual follow-up patients, I really love, because you're not just reviewing their HRT, you're looking at their lifestyle, you're looking at the way, like you say, they're interacting with their family. They've often got different jobs, they've been promoted, or they've started work when they haven't for a while, and you're really setting them on a path, like you say, of preventative healthcare as well. So it's not just making them feel better. You know, if someone's really clinically depressed and you give them antidepressants, of course they'll feel better, but you're not going to strengthen their bones and reduce their risk of heart disease, are you?
No, absolutely.
And I remember you telling me when we first met, actually, you were doing some reviews of medication, and you would just be taking people off medication, didn't you?
Yes, I seem to spend my life trying to take them off medication, but like I said, once you see it, you inspired me, Louise, and once I could see it, and then you give them HRT, and actually they can stay off that medication, which is a really powerful thing, I think.
Because that's medications often people are on sometimes over years. There's layers of medication, so people have often started on, say, antidepressants for their low mood, and then they muscle and joint pains, they might get painkillers, and then their blood pressure increases without estrogen, so then they're on a blood pressure lowering treatment, and then they're found on a review to have raised cholesterol, so they then have a statin, and then and then maybe they're developing osteoporosis, so they're on a bisphosphonate, and before you know it, there's 5 or 6 medications on a prescription, aren't there?
Yeah, absolutely. And it's so sad and disheartening. And I think then they feel so much better on HRT, and you think, goodness, that would have been, wish we'd started there, just replacing a woman's own hormones and seeing how they do.
So one of the things often is that people talk about go and see your GP for HRT, or going to see your GP if you're struggling with symptoms, whereas a lot of the time I'm thinking, well, the GPs are overwhelmed anyway with everything else that's going on, and menopause care, actually, I often think is better done by people. I'm not being rude about doctors, because I am one, but as doctors, we often a bit chaotic. We don't follow protocols the same way, and we've got other skills as well. But I've always thought, wouldn't it be better if it was taken way more from GPs and it was given more to nurses and pharmacists? And, a lot of pharmacists now, like you, can prescribe.
Yes.
So having a bit of autonomy, being able to see people and actually prescribe for them in a way that's safe is actually really good. And I think menopause care is one of the few things that really a lot of nurses and pharmacists, if they prescribe, can do with more autonomy probably than some other areas of medicine. So we've got quite a few nurses and pharmacists, haven't we, working with us?
We do, and you're right, and we also generally tend to have a bit more time, don't we? And so, my little team that I look after, we look after patients in between their appointments with their own clinician as well, so we can help them just, for quick questions, or if they're unsure about things, we can reiterate messages and things. So that's really lovely that the patient just gets an experience where they're looked after in between appointments as well as during their appointments. But yes, I see patients as well 2 days a week of my own. So, and then you develop the relationship with the patients, and it's so lovely because you learn so much from the patients as well, don't you? So, but yes.
Yeah, I mean, I've always said it's a great privilege being a doctor, and it really is being any healthcare professional, because even though our clinic is private, of course, we see people from all socio-economic backgrounds and actually different ethnicities as well. So we're still exposed to lots of people with lots of different stories, lots of different cultures, lots of different ways that they've come to the clinic. I've seen a lot of people who it's been their birthday and Christmas present combined from every single family member, because they're desperate to feel better and they can't get help on the NHS. And so they're not all people that have money, but it's actually still really rewarding because we can help so many different communities. And like you say, there is this ripple effect. We know that every person that we help, they're often going to educate other people. And a lot of people then say, because I've spoken to one of my friends and now she's gone to her doctor because she's got more confidence, or she's gone and got HRT elsewhere. So I feel like we're sort of spreading out a lot more. And I know for some people, they feel a bit frustrated seeing my name or listening to our company's name. But actually, I know that we're helping far more people than just the people who pay to come and see us, don't they?
Yes, I think so. And it's really lovely when you end up treating a whole friend group. I always love it when they tell me about how they heard about the clinic and what made them make the appointment. But then also on the other side, I found that, in the beginning, it can take some time to get the HRT plan right for that individual patient, because that's what we focus on, isn't it? It's just individualizing care. And then afterwards, often GPs will be quite happy to prescribe once the patient's stabilized, because that can take a little bit of time, can't it? So
absolutely.
I guess it's just helping. Yes.
Yeah. One of my friends recently said, HRT prescribing is really easy. It's just the same for everyone. I said, no, it's absolutely not. And during the perimenopause, it can be really quite difficult to get the right dose, can't it? And then, we do spend a lot of time individualizing both the type and dose, and it can really change. Even with the same patient, it can change over the month sometimes. So it's very important that people are given the right dose, the right type. But we can't always get the type that we want, can we? And I was thinking about this today, actually. So 5 years ago, I was away with my daughter because she was doing a trombone boot camp in Budapest, and there was a shortage of, then it was Everol patches. And I remember getting hold of somebody in the government to say what's happening, and speaking to a chief pharmacist for NHS England and saying, this is awful, this is outrageous. Actually, I cannot function without my Everol patches. And the estradiol don't stick on for me, the gel just slides off, and I was really worried, personally, of course, but I was also worried for all my patients, and they said, oh, it's only a short term, and da-da-da. And it took a few months of a lot of frustration, and then actually now Everol's been taken over by another company, Theramax, and that's absolutely fine. But I just then thought, goodness me, we've only just started to increase prescribing then. Some of my work had only just started, but now we've had the Davina documentary. We've had a lot more awareness. HRT prescribing has gone from 10-ish% to about 16%, not 60, 16% of menopausal women. It's still the minority, although we know for the majority of women, HRT has more benefits than risks. And we've been, as you know, none of us who work with us do any paid work for pharmaceutical companies, but we have met with pharmaceutical companies over the last 5 years and said, the demand is going to increase. It's going to increase exponentially. What are you doing? How are you going to improve the stocks? And people talked about like a spike, like, you know, with COVID, we had this sort of spike. I said, it's not a spike. It's going to continue as women understand the importance of considering hormones for their future health as well. And there was still this, oh, but we can't. And then some of the way that they look at their stock is looking at what the government predicts. And that isn't always true, because I guess many people who work or report to the government aren't that keen about women having HRT. So there's been this going on. But we've felt it and seen it. And then there's been shortages of gel. There's been shortages of estradiol. There's been shortages of the testosterones. And now there's shortages of Utrogestan. And it's incredibly frustrating, isn't it, Faiza?
Yes, it is. And I mainly feel sorry for women. One of my main things has always been, and actually the whole team, is we don't want patients, once they're on HRT, you definitely don't want them to have to interrupt their treatment. And if they're on estrogen, you definitely want them to have progesterone if they still have a womb, or if they've had a history of endometriosis or whatever. So it's so important that the treatment isn't interrupted. And I was reflecting on this because it's been a tough few months, you know, with just making sure that treatment isn't interrupted for patients. And I thought, gosh, but still we're lucky. At least we have alternatives that are safe, they're effective. We can talk through different options with patients. I grew up in Africa, and our family home is still in Kenya. And I know for a fact that HRT is, well, you know, there's hardly any in Africa. It's very difficult to get a hold of. So I guess on the positive side, isn't it great that we have these alternatives so we can make sure that patients can continue treatment? But yes, it has been a big challenge. And I guess all the teams in Newson Health have been working so hard in just contacting patients. The CloudRx, the pharmacy, have been fantastic. Also contacting patients saying, please let us know if you're close to running out, let us know. And then we've been phoning patients and actually not charging for any of those phone calls. And this is the pharmacist in me, Louise, because I like to call the patients, because I like to know that they know how to use the alternatives, and I can explain everything properly and give them the options. Because I've come across so many times where patients may not use whatever's prescribed, you know, in the best way, and then they don't get the best effect from it.
Yeah, it's really important, because medication, it took me many years to realise that it's not about just signing a prescription, it's about the compliance and people understanding, because if you don't understand, you're not going to do it. The amount of times I did home visits and I'd look at all the medication we'd prescribed from the practice, and then I'd open the person's kitchen cupboard and everything would fall out on me because they would never take them, because they didn't understand how to take them, or they didn't know what they were for. And so it's really important. So if we just start at some of the basics, if you don't mind. So HRT is 3 letters, hormone replacement therapy. I find that a bit frustrating because we're not always replacing hormones, we're just topping up what's missing, aren't we?
Yes, definitely.
But the main hormone we always prescribe, usually, is estrogen, isn't it? So there are different ways. If you just can you explain the different ways of having estrogen?
So mainly we prescribe it transdermally, which means through the skin. So it comes as a gel, a patch, or a spray. But just going on the example I was saying about making sure we explain things properly, I came across a patient the other day, actually, where she was applying 3 pumps on the same arm and wasn't feeling better, you know, and just explaining, actually, if you spread it out, the better the absorption, because you need a large surface area. Those practical tips are so important and can make all the difference.
I did some training a few years ago to some local GPs. We had in fact, it was 2 hours, so it was an hour of just the theory and then an hour more about practical prescribing and everything else. And then about 6 weeks later, the GP phoned me up and he said, I'm a bit confused because you've sent someone out from your clinic on oestrogen gel and Vagifem, which is a vaginal oestrogen. I said, yes. And what else? And he said, well, no, that's all. She's had a hysterectomy, so she's just on the oestrogen. But why on earth would you give the gel and the vaginal preparation? I said, well, the vaginal preparation is only for localized symptoms, you know, related to urinary symptoms or vaginal dryness. About a fifth of women have both. He said, yes, but she's on the gel. And I said, yes, I don't really know what else you want me to say. He said, yeah, but surely the gel's for the vagina as well. And I was, oh dear, which bit of me doing this practical session where we had the placebo gel rubbing on the arm or the leg did you not understand? And then there was this sort of embarrassed silence at the end of the phone. And I thought, gosh, that's it. And it is easy to misunderstand when you're prescribing and you haven't seen or you haven't prescribed something before. And it's very obvious for us because we're prescribing it all the time. And, you know, sometimes I say to patients, don't get too stressed. Whereabouts on the arm it goes or whereabouts on the legs. I know it's licensed for the outside of the arms and the inside of the thighs. But actually, I say you can put it on your face. It doesn't really matter. It's just using the skin as a vehicle, isn't it, to get it into the bloodstream. That's what we're doing.
Yeah, definitely. But I think also that, you know, we always like to prescribe each hormone separately so you can individualize the dose easier. But in the first appointment, there's quite a lot to take in, isn't there? And yes, you know, we do letters. Now I'm quite particular about my letters and try and make it very specific so they know exactly and can refer back to it. But still, I always think, you know, you don't know because what they'll remember. And, you know, just reinforcing that information is quite useful. So actually, all the calls we've been doing, like I say, all my team have been doing all of these for free of charge. We've actually, you know, been able to check in on patients and just reinforce key information, which has been really great. So which I'm trying to find a silver lining with all these shortages.
Well, you're great because you're always so happy, and I know it's very difficult. So we've got estrogen, and at the minute, there's no problem with estrogen gel. There's no shortage. Averell patches, and they come in different strengths. There isn't a shortage, but Estradot, the small ones, are still difficult to get hold of, aren't they?
Yes, it's intermittent, so some all the strengths aren't available all of the time, and so it changes. But yes, hopefully that's going to improve soon. Yes, but on the whole, estrogen is available.
Estrogen's not so bad, and the vaginal preparations of estrogen are fine as well. So the big problem that people are talking about, which is a real problem, is Utrogestan, and Utrogestan is micronized progesterone, isn't it? So it's the body identical progesterone. It's called micronized because it's made into very small particles, really, isn't it? And it's suspended in oil just to help the absorption. But when you look down the microscope, it's the same structure as the progesterone people produce from their ovaries when they're younger. Any other progesterone is a synthetic progestogen, isn't it? So it's been chemically modified, and it depends on what type of progesterone it is as to how it's been modified, isn't it?
Yeah, definitely. And having micronized progesterone is first choice, isn't it? Because then we know it's safe. It doesn't affect other things. It doesn't affect your blood pressure, your cholesterol, and that's the one women want to be on long term, don't they? So,
yeah, because the studies have shown that it doesn't have a clot risk. It doesn't have a cardiovascular risk. It's probably either neutral or beneficial on blood pressure as well. And it has less side effects actually because you're giving the proper progesterone. The alternatives, which there are, and you know, years ago we used to prescribe all the time the synthetic progestogens. It's only now we can have the Utrogestan. It's easier, but the synthetic progestogens can come as tablets, can't they? And they do have a small risk associated with them, small risk of clots, small risk of heart disease, which sounds more scary than it is actually, because for a lot of people their background risk is very low. So increasing a low risk is still a low risk, isn't it?
Yeah, definitely.
And then the whole breast cancer risk has only ever been shown with synthetic progestogens, but again, it's never been shown to be statistically significant, and the risk is far lower than it is with other risk factors for breast cancer, for example, not exercising or being overweight or drinking moderate amounts of alcohol. All those are still really low risk factors, but they're actually more than taking a synthetic progestogen. And then we've also got the Mirena coil, haven't we? So can you explain a bit about the Mirena coil?
So the Mirena coil is, I would say in terms of safety and efficacy is on the same level as Utrogestan, would you say, Louise? And the great thing about that is that, it can be left in place and replaced every 5 years, so you kind of forget about it, and it just helps to balance the effect of estrogen on the lining of the womb, keeps it nice and thin, and so in that way, yes, you don't have an additional thing to think about to take or insert into the vagina. So it's great from that perspective. And a lot of our patients quite like that, because it also has a 2-in-1 effect, doesn't it? Because it can act as a contraceptive if you're perimenopausal, for example.
And it often means that women don't have periods, which again is really nice.
Yes.
One of the problems often is people actually getting the Mirena coil because there's been a real restriction in their use in general practice and in the NHS. A lot of clinics will only give them for contraception. So if you're in your 50s and you're having one replaced maybe or inserted for the first time and don't need contraception, it can be difficult. And we do have Mirena coil clinics running throughout our clinic, and people sometimes travel for miles actually just to come and have a Mirena coil. But that is actually really good. People, I was talking to a lady yesterday and she said, "Oh no, I don't fancy that." And I said, "Have you seen the size? They're really small." It's actually not a difficult procedure. You want obviously someone who's used to putting them in, and once they're in, people really don't remember, they don't feel them or anything else. And if people don't get on with them, they can be very easily removed, can't they?
Yeah, absolutely. But I suppose it's a patient choice, isn't it? And again, so nice that we have these different options. But yes, Mirena is one of my favourites, just because you can forget about it for 5 years and not have to think about it. But yes,
absolutely. And then the other option there are different preparations of progesterone, which some people might not realise. So in the UK, we can only have the oral as the Utrogestan. But for many years, actually, for women who don't tolerate Utrogestan orally, we can use the oral Utrogestan capsules vaginally, and they sort of just melt into the vagina, and then you have a higher concentration actually in the womb, which is where you need it, and women often have less side effects. So we've done that for many years anyway. Obviously, if you can't get the Utrogestan, it doesn't matter whether it's oral or vaginal, you just can't use it. But there are alternative progesterones, aren't there, we can use vaginally.
Yes, there's 2 in the main that we've been using is Cyclogest, which comes as a pessary, and also Utrogestan. And the great thing is that they're micronized body identical progesterone as well. So essentially the woman is getting the same ingredient. And those are the calls we've been making to patients just to explain how to use them. If they've been used to using them Utrogestan orally, it's quite a change. But
so with the those pessaries, they come as a 200 milligrams. So they can, if people are having 100 vaginally, they can be cut in half very easily. And they're very small actually, aren't they?
Yes, they're very small, very malleable, and easy to cut. So this is what we explain when we call and explain what the alternatives are or what the options are. And the vast majority of patients have chosen Cyclogest or Utrogestan. So and that's fine. At least we've got something, so they don't have to interrupt their treatment.
Yeah, absolutely. And using it vaginally, some people are quite scared that it's going to disappear or they're going to insert it too far, but you can't insert it too far, and it usually just melts very easily. People don't usually get a discharge or anything. And if they are using something like Vagifem or another vaginal hormonal preparation, it's quite safe to use the 2, isn't it?
Yeah, absolutely. And we normally would say use the progesterone first and then any vaginal estrogen afterwards, or opposite ends of the day. That's fine too. And I guess this is why it's so important. I've felt it's so important to call patients, and we've been doing that during the shortages, just so we can answer some of these practical questions and make sure patients,
they really
understand fully.
Yeah. And then the other alternatives. So there's always alternatives, and it's always. Yes. I think it's really lovely for patients to know. I never leave, or I never want them to leave my consulting room until they know there's an alternative of anything, because people, if they get side effects or whatever, it's quite nice to know. So there is a capsule tablet, or a capsule called Bijuve, which is a oral body identical combination. And so it contains lowish dose, 1 milligram of estradiol, which is equivalent-ish to about 50 microgram patch, isn't it, or 2 pumps of gel. I say ish because it all depends how it's absorbed into the body, of course, but it also contains 100 milligram of Utrogestan. So it's a way of getting it. You can't split it out. It's all there as a combination. It's been around, actually in America, it's called Bijuve, and it's been around for quite a long time. It's Bijuve over here. Quite a few NHS areas are still unable to prescribe it because it's not on the formulary, which is very frustrating. But we can prescribe it through the clinic, and in some areas they can prescribe it. And that can be quite a good combination oral preparation, can't it, for some people?
Yes. Yes.
And it's not been shown to be associated with risk of clot like the synthetic progestogens as well. So sometimes if people are using that or taking it, they might have to reduce the dose of their estrogen a little bit, depending on the way how it's absorbed. So that's an option. And then there are combination patches that we sometimes use as well, aren't there, which contain estrogen and it's a synthetic progestogen, but it's through the skin. There probably is a small risk, this risk of clot and heart disease, but it's very, very low, especially because it's low dose, it's absorbed. But again, those combination patches only contain 50 micrograms, don't they, of estrogen?
Yes, and if you want to titrate, it's much easier sometimes to have the products separately so that you can individualize treatment, can't you? Because then you're actually, you can't have any more estrogen. Because the skin is a barrier, and sometimes you will need more depending on how you absorb.
Absolutely. So it really varies, and sometimes it can take a while to get the right one. And I always say to people, when you change, just try and bear with it for a good 2 or 3 months, because sometimes people get side effects initially and then they settle down. So there are choices, there are options. There's more information on Balance website as well, and we've written some information about alternatives to Utrogestan. One of the reasons there is a shortness, obviously, because there's increased demand, but they are making they've built a new factory, and it's supposed to be in full swing by the end of the year. So I think this is going to be an intermittent problem. I must say that Besons are trying as hard as they are. There is still stock, but obviously they've got to distribute it throughout everybody. And we really shouldn't be advising that people have estrogen on their own. It's okay for a few weeks. They might get bleeding, but certainly any more than that, it does help protect the lining of the womb having progesterone. So really shouldn't be having estrogen on its own if at all possible.
Yeah, and this is why, there is stock and it is coming in, which is really reassuring. And also we're trying to find other pharmacies that have stock just so that we can get HRT for our patients. But yes, it's not as if there's no stock. It's just that for a while we might have to be careful about making sure everyone has some treatment to continue with.
Yeah, and at the minute the guidelines are that we should only prescribe 2 months of Utrogestan at a time. So that's 2 months whether it's NHS or private. Of course, if you have one of the alternatives, you can have longer. So anybody who's listening and is struggling, it would be worth probably going to see pharmacists first, find out where our stock is. They often know more, actually, the pharmacist, than just going to your GP. And then obviously read some information, empower yourself with knowledge, and then decide which alternative is best for you. And then it's easier that way, and then going pre-armed with the information so you can then have a shared decision-making consultation with your GP, rather than your poor GP who might not necessarily know all the alternatives. So having information is really good. So I'm very grateful, Faiza, for your time to do this podcast at very short notice. But before we end, just three take-home tips I always ask for. So I'm very keen to ask for 3 tips for people that are struggling or worried about the Utrogestan shortage, what 3 things would you say to them?
So I think the first one I would say is just, the intention of the serious shortage protocol of only having 2 months is just so everyone has treatment and no one's treatment is interrupted. So please only order what you need. And it is frustrating that you have to do it every 2 months, but hopefully this will get us out of it, and the manufacturers will catch up. And then second, I would say, just be organized, make sure you allow enough time as well. So, when you've got about 2 weeks of treatment left, that's the time to order some more, just in case you have to have a phone call for an alternative, and go through that. So leave plenty of time and don't wait till the last minute to order, and just make sure you've got enough of both, estrogen, progesterone, if you're on both treatments. And then last but not least, I would say, we're here to help. Please, we all, the pharmacy will communicate to us if you let them know that you're close to running out of treatment. You can contact us as well. So as long as you've had an annual review or been seen in the last 12 months, we're absolutely happy to help you prescribe an alternative. Or even if you get your prescriptions through the GP and just come and see us for annual review, that's fine. We can always recommend different options for you to discuss with your GP. That's fine too. So we're here to help. Just get in touch.
Very good. So absolutely. So if you're our patients, obviously get in touch. But if you're not our patients, there's lots of free information available on the Balance website, and just hopefully we won't be having more of these conversations, but the good thing is it means that more people are taking HRT, meaning that future health for those women will improve. So there are good points as well. So thank you again so much, and it's been great having you on the podcast today. So thanks, Faiza.
Thank you, Louise.
For more information about the perimenopause and menopause, please visit my website, balance-menopause.com, or you can download the free Balance app, which is available to download from the App Store or from Google Play.